Hi, my name is Kristen Berning. I want to thank Megan for inviting me to speak to the Iowa Breastfeeding Coalition today. This presentation has been pre-recorded. I did have some patient commitments, so it worked out better for me to just record a presentation for you to watch at your meeting. If you do have any questions, you can email me. I will provide that in an upcoming slide. Thanks. My email address can be found on this slide, drkristenberning@tryexceptional.com. First, I'd like to introduce myself. I am a general dentist in Dubuque, Iowa, and I practice with my dad, Dr. Ted Murray, and my sister, Dr. Alexia Otkin. I graduated from Wahlert High School in Dubuque, and then I attended the University of St. Thomas in Minnesota. Then 4 years of dental school at the University of Iowa College of Dentistry. Since graduating from dental school in 2006, I've been practicing at our dental office, Exceptional Dentistry, in Dubuque, Iowa. Today, I will share my story and how I got into this field of tongue ties and lip ties. I will discuss how tongue and lip ties affect breastfeeding, including signs and symptoms, and classification. I will also discuss the laser frenectomy procedure that I perform in our office. One thing I won't be able to discuss in this presentation is how to diagnose tongue and lip ties. That does take a long time to learn and hands-on experience training and can't be covered in just a short presentation like this today. So, how did I end up here? How is a dentist helping moms and babies with breastfeeding? Looking back, here are some moments that brought me here today. My mom breastfed my two sisters and me. When I married into the Berning family, my husband's older sisters were great role models for breastfeeding as they had breastfed their children. Here you can see 10 nieces and nephews. Now there are 30. In 2007, we welcomed our first child, and here's a photo of me breastfeeding her in the hospital. My husband, Tim, and I have 4 kids. I breastfed all of them, but there were many challenges and hurdles along the way. Thankfully, I had a lot of support along the way in my breastfeeding journeys. First of all, someone recommended to me the local breastfeeding group called the Mercy Milk Network. There were 2 IBCLCs there and great mom-to-mom support. I went every time I could, and this is where I fell in love with breastfeeding. I also had a lot of family support from my in-laws, as mentioned earlier, and from my immediate family. I brought my babies to work where my mom babysat them until they were about 6 months old so I could breastfeed between patients. When our third baby was born, breastfeeding was different from day one. He had a shallow latch, and it felt like he was just chewing instead of sucking. We tried many modifications, including a nipple shield, and tried to make that latch deeper, but it just wouldn't help. I had cracked and bleeding nipples for 3 weeks and a thrush diagnosis when he had white patches inside his mouth, and I had a lot of nipple soreness. I was sitting by a mom at the Milk Network support group, and she suggested that he possibly had a tongue tie. She had experienced that with her daughter, so she gave me a recommendation on an ENT physician to take our son to. In the meantime, I asked the lactation consultant and the pediatrician, and they were both not sure if it was a tongue tie. I did make the appointment, and his tongue tie was released when he was 3 weeks old. His latch was improved. I went on to breastfeed him for 12 months, and I do feel like that saved our breastfeeding relationship. When Clara was born, she had a shallow latch, but not as bad as Teddy's. She did pop on and off the breast frequently, was gassy, frequent feeds. I had sore, cracked nipples still at 3 months. I was dreading some of the feedings due to the pain. I had clogged ducts and mastitis. I did look under her upper lip and notice how tight her lip was, how thick it was, how difficult it was to lift her lip. I started learning that dentists were treating lip ties and tongue ties in babies who are having difficulties with latch, so I was on a mission to learn more. This was a turning point when my tongue tie learning journey began. Why? I loved breastfeeding, and I didn't want other moms and babies to fail at breastfeeding if there was a way to help. I have learned a lot from these educators who are considered the top in their field of tongue ties and lip ties. Pediatric dentists, Dr. Fred Margolis, Dr. Larry Kotlow, and Dr. Richard Baxter. And then ENT physicians, Dr. Bobby Gahary and Dr. Sarush Zaghi. Also, I've taken a course and learned a lot from Dr. Alison Hazelbaker, who is an IBCLC. I had already been using a laser in our practice for many procedures, including frenectomies on older children and adults. My daughter Clara was my first infant patient when she was 4.5 months old. I released her upper lip tie and her posterior tongue tie. She did show an improved latch, and many of the problems that we had listed on the earlier slide got better. So, what is a tongue tie? A tongue tie, or partial ankylosglossia, is an unusually short or thick lingual frenulum, a membrane connecting the underside of the tongue to the floor of the mouth or the alveolar ridge. A lip tie is an unusually short, thick maxillary labial frenulum, a membrane connecting the upper lip to the alveolar mucosa, the attached gingiva, and the periosteum. There can be many reasons for breastfeeding failures and difficult breastfeeding relationships, but tongue ties can be one of those reasons. This diagram shows the difference in how tongue tie can affect a latch, with normal tongue position on the left, the mid-tongue being able to elevate to the palate, and the ability to have a deep latch. And on the right, a tongue tie often results in a shallow latch, and the mid-tongue cannot elevate to the palate. There is a wide variation in the research literature about the incidence of tongue tie, but it likely ranges from 2 to 11%. However, there's also a lack of universal clarity in what is being identified as a tongue tie and how to classify tongue ties. There's also a strong genetic component. Tongue ties have been around for a long time, as they are mentioned in the Bible. And in some hospitals, for many years, the instruments for tongue tie releases were also packaged with circumcision instruments. Symptoms of tongue ties and lip ties in infants include poor latch, slides off nipple frequently, pops on and off, falls asleep prematurely during feeding, colic and gas symptoms, reflux symptoms, poor weight gain, very frequent or continuous feeding sessions, gumming or chewing of the nipple, clicking sound while sucking, unable to take a pacifier or bottle, upper lip curled under while latched, upper or lower lip does not flange, milk runs out the side of the mouth while latched. For the breastfeeding mother with a tongue-tied or lip-tied infant, symptoms may include creased, cracked, bruised, blistered, or bleeding nipples, severe pain when baby latches and or throughout the feeding, poor or incomplete breast drainage, infected nipples or breasts, plugged ducts, mastitis, nipple thrush, low milk supply, and frustration or disappointment with breastfeeding. In 2004, the American Academy of Pediatrics released this statement: tongue tie is a significant clinical entity which, when symptomatic, should be treated as early as possible to minimize this breastfeeding problem. Surgical treatment is safe and effective. Complications are rare, and general anesthesia is not required. Donna Geddes published some important research on breastfeeding using ultrasound images. Her research showed that the baby doesn't milk the breast to nurse, but instead creates a vacuum to draw out the milk. The upward movement of the tongue, elevation, not the outward movement, the sticking out, called protrusion, is what is important. This was an important finding, which helped explain why a posterior tongue tie that prevents mid-tongue elevation can affect breastfeeding. This is how I examine for tongue ties and lip ties in our office. First, it's very important to gather a thorough history of the mom and baby. Second, I do a knee-to-knee exam. This is the best position to properly assess for tongue and lip ties. Next, it's important to do a functional assessment looking at both the anatomy, which is the tissue thickness, tightness, the location of the insertion of the frenulum or frenum, and function, looking at mobility, elevation, cupping, protrusion. I do use the Hazel-Baker assessment. Dr. Betty Carolus was one of the first to classify types of tongue ties, including anterior tongue ties and posterior tongue ties. The images show the type 1 tongue tie is where the frenulum is attached from the tip of the tongue to the alveolar ridge. At the other end is the type 4 tongue tie requiring a digital exam. That means fingers lifting the tongue to find that posterior tongue tie that is submucosal. Dr. Larry Kotlow has the Kotlow classification of abnormal lingual frenums based on the location of the attachment, but his do go in a different order than Dr. Betty Carolus. There's also something called the Murphy maneuver, named by James Murphy, a pediatrician, and he describes using the finger to sweep underneath the tongue to feel for speed bumps. That would be the restriction created by the lingual frenulum. There are some assessment tools that have been validated. The first one is the Assessment Tool for Lingual Frenulum Function by Alison Hazelbaker, also called the ATLIF or HATLIF. This is what I was trained on, and so this is the one I'm most familiar with, and I do use this for my infant exams. Another good validated tool is the Lingual Frenulum Protocol with Scores for Infants, developed by Roberta Martinelli. For lip tie classification, there is not a functional tool, but Dr. Kotlow does give us a classification based on the location of insertion of the maxillary labial frenulum. So in an assessment, it's very important to look at the appearance and determine if it's restrictive or not. You can look at thickness, the point of insertion, if there is an indentation at the papilla or alveolar ridge, and if there's any lip blistering. Regarding the latch, you can look and see if the lip does curl under. When you're lifting the lip, you can see, is there tissue blanching? Does it turn whitish or yellow from the tension where that lip tie inserts into the gum tissue? And how easy is it to lift up the lip? Here are some photos of some more severe lip ties I have seen in our practice. I do also see normal tongues and lips on babies in our practice, and here are some photos of tongues and lips that were normal. These frenums or frenulums were not restrictive, and these are not lip ties. These are not tongue ties based on my assessments, and I did not recommend treatment on these. There is a lot of evidence in the literature that supports treating tongue tie for breastfeeding problems. And a statement from Dr. Bobby Gahary sums it up when he said, additionally, there are currently no studies that show frenotomy does not help breastfeeding symptoms. They universally show improvement regardless of study design. When families come to our office, we do have a separate consultation room where we seat them for the exam, the consultation, and the discussion of the appointment. I use a light scalpel CO2 laser for the frenectomy procedure, which includes treatment for tongue ties, lip ties, and, when referred by a therapist, buccal ties. I do treat many ages, from 0 up to around the age 1. The toddler age is not always easily treated in office, so that is an age I usually don't treat. But then again, when kids will cooperate at around age 4 or 5 and up through children and adults. A typical infant appointment goes like this. First, we review the breastfeeding history. We take photos and I do a functional assessment. Then I discuss the findings with the parents, if I recommend the procedure, and then the parents decide if they want to proceed with the procedure or not. Sometimes the infant needs more therapy before we decide if we're going to do it, or they don't need the procedure and they are referred back to a therapist or lactation consultant. If we are going to do the procedure, we obtain informed oral and written consent. I place topical or local anesthetic. We then take the baby to the treatment room where we use a swaddle, safety glasses, and 1 to 2 assistants to stabilize the baby. I use gauze for lifting the upper lip, a grooved director for lifting the tongue. Then I use the laser to release the lip tie or tongue tie, which takes 5 to 20 seconds per area. We take after photos. We return the infant to the mother to breastfeed or bottle feed immediately after the procedure. It can be very beneficial for many of these babies to have a coordination of care where they are receiving some adjunct therapies or continuing to work with a lactation consultant or a craniosacral therapist or an occupational therapist, speech language therapist, physical therapist, etc. Someone who has some advanced training for these babies who maybe have many compensations that they're working on. I do also recommend and demonstrate the gentle stretches that are also called active wound management 6 times a day for 4 weeks. Each session only takes a minute or so to perform, and this does help prevent the tissue areas from wanting to heal back together tightly or reattach. In the first few days after a frenectomy procedure, babies might be more fussy than usual. Improvement in latch and symptoms can sometimes be immediate, but sometimes it can take 1 to 3 weeks for a baby to relearn how to latch better and for the tongue to improve its strength. There are many success stories after laser frenectomy procedures, including mom having the end of breastfeeding pain, baby having improved latch, more complete, efficient nursing, mom having breast feel emptier after feeding, baby weight gain improving, baby able to get off reflux meds, improved milk supply, colic and sleep can improve. Many moms drive to our office from Northeast Iowa, Southwest Wisconsin, Cedar Falls, or the Iowa City, Cedar Rapids area. Tongue ties in children and adults can also cause problems and symptoms listed on this slide, and these are patients that I can also treat in my office. Closing with some final thoughts. Breastfeeding is beneficial to mother, infants, our community, and our environment. Tongue ties should be considered as a reason for breastfeeding failure, and the frenectomy procedure can be safe and effective. If breastfeeding problems are not resolved quickly, some moms will often give up on breastfeeding in the early days or weeks. The frenectomy procedure is not just for breastfed babies. A frenectomy can also be indicated for a tongue-tied formula-fed or exclusive pumping bottle-fed baby for poor weight gain, poor latch on a bottle, leaking milk, colic, and extended feeds. During the newborn physical exam, it's important to screen for tongue ties in case there could be a feeding problem caused by a tongue tie. To do this, lift the tongue to look for the lingual frenulum and see if it could be tight or restrictive. Use 2 fingers to lift the tongue or sweep the finger under the tongue side to side to feel for resistance. These are babies that I've seen in my office. One of these babies was told by a doctor that it would be a significant surgery to have done, and it was not encouraged for them, but they were having significant feeding problems. Another one of these tongue ties was not recognized by a pediatrician, but mom had excruciating pain and the baby wasn't gaining weight, so they found our office. And share the knowledge that you have with other moms or medical providers who are interested in learning more. If you want to learn more about tongue ties, listed on this page are some great resources. Richard Baxter, pediatric dentist, wrote this very thorough book about tongue ties. There are also these websites. And I just recently came across this course here at the bottom that helps people learn how to identify tongue ties. And it's an online course. Megan also asked me to mention the referral process. Patients or parents can just call our office directly for an appointment. Thank you again so much for having me speak to your group. This is a topic that I am passionate about because it has impacted my life greatly. If you have any questions, you can email me at this email address listed on the slide. Thank you again.